Today we're going to be talking about building your myelofibrosis care team. This is a really important topic because your care team is not just your doctor. And I think that's a misconception that patients often have, that their doctor is their care provider. And while, yes, the doctor plays this important role in this, they're not the only one. And today we're going to be speaking with someone who holds a very important role and a very specific role to helping MPN patients. And they're able to do a lot. So I really wanted to highlight what they do because I think that it's really beneficial. So with that, I'm going to introduce our speaker. Patrick is a registered nurse with over 9 years of experience. He began his career working in a hospital in a neurologic telemetry floor before transitioning over to a cardio intensive care unit after 2 years. Then 3 years ago, he made a pivotal career move into the outpatient cancer care, where he now serves as a clinical nurse coordinator, a decision that he considers the best of his career. I had the fortune of meeting Patrick at an event at a conference in December, and he is one of the kindest people I've met. And his heart is completely dedicated to helping MPN patients. So I am so thrilled that we have him here to speak with us today.
Thank you, Dalton, for the great introduction. Am I okay to share my screen now?
Yep, go ahead.
Okay. So, as Dalton, um, just once. There we go. So for on the agenda for this presentation, I'll expand a little bit on my background that Dalton has gave you. I'll expand on the clinical nurse coordinator role and go into more detail about that. And then I will be finishing up with generalized tips for patients. So let's just dive right in. The diseases that I most predominantly work with, I work with a lot of MDS. I work with a ton of MPNs, and I work with a lot of AMLs. MDS is myelodysplastic syndrome, and that's kind of like a pre-AML or leukemia. And I work with all of the MPNs, essential thrombocythemia, MPN, myelofibrosis. I also work with some iron deficiency anemia patients and some patients who have coagulopathies. So diving into what exactly does a clinical nurse coordinator role do? Generally, depending on the type of year or the time of year, I'm a clinic nurse about 50%, and this can change to 70% depending on what's going on. Case management is about 40%, and dealing with insurance, which I've titled Insurance Fund, is about 10% of my job. So for a clinic nurse, which is the first and foremost, I'm a kind of a middleman between my patients and the doctors. And what that means is that when a patient calls in or sends a message saying, hey, I have these symptoms, it's my job to get more information and then forward that on to my provider so they can make the most, so they can have all of the information present to make the best decision for what is going on, whether that's patients that are having new symptoms that we need to have evaluated, or if it's just, hey, I'm going to be having this procedure. Is it okay with what is going on? Another big part of my job is to communicate any changes to patients, whether we change their schedule, we change their medications. It's my job to help make sure the patients are kept in the loop. Another big one is patient education. With the patients who have MPNs, one of the big things of education that I actually do is injection teaches for interferons. So a lot of times they'll have a meeting with the pharmacist to go over what about the medication they need to know about, I'll reinforce that and say, if you have these signs and symptoms, you need to give us a call. And then I'll also actually teach them how to self-inject, which can be the weirdest thing most patients have to do. Um, I do a lot of lab reviews with patients where if they're stable or if they're even coming in to see if they need their blood transfusion that's scheduled later that day, we'll sit down with a patient, we'll review what their labs are and kind of go over what their needs are, if they have any symptoms. A lot of times if a patient is scheduled for blood or platelet infusion and they're having symptoms and they're only a little bit above threshold, I might use that as leverage to go to my provider and say, hey, we need to give them this transfusion because they're having symptoms. Um, and then I do a lot of proposing orders. We have a lot of patients that are on recurring blood transfusions, platelet transfusions, labs. I'll pen referrals to the doctors. So it just depends on what the particular needs of the patients are. Case management. One of the biggest parts of case management is that we have a lot of patients who don't live within the city, within Seattle. And so I coordinate with them to try to help get their routinely scheduled labs. So that way they don't have to come all the way over to Seattle. A lot of times I've discovered with outside labs, it depends on who's working there, if they're able to look up the orders in general and to make sure all of the orders get drawn. I've had many times we order 3 labs, a complete blood count, a complete metabolic profile, and maybe an LDH, depending on what's going on. And they'll draw only like the complete metabolic profile, which is the most useless of the 3. So it's just a matter of coordinating the local labs with patients. I also help coordinate with local care. We do a lot of what we call a consult visit, where if a patient is kind of their condition overwhelms the doctor and they're needing expert consultation, they will come to our doctor for a referral appointment. And while we see them and they're still one of our patients, it is the local oncologist who is reviewing their labs, prescribing the medications. And so part of my job is making sure that they get our recommendations. So I'll fax them the note and then I'll call them the next day and check in and see if they have any questions, make sure they got the note, and just make sure everybody is on the same page. And then I also check in with the nurse because depending on what regimen the patient is on, they might need a little bit more support. And so I'll just make sure that the nurse understands kind of what they're watching out for if they're unfamiliar with this treatment regimen. Another part of my job is faxing outside orders or orders for outside scans and outside referrals in general. Occasionally we'll get patients that are moving to Washington State, but not necessarily Seattle, and we're their first contact in the state. So I might be helping them set up, sending referrals to a primary care provider, a local oncologist if they're not within a certain area, and then any scans that they may need. That way they don't necessarily have to drive halfway across the state in some cases or more. Another big part of my job is helping patients to remind them that they are due for labs. This is especially big for patients who are on the every 3 months and been stable for like the last year or so on their medication dose. So most of the time it's just sending them a MyChart message and being like, hey, go get the labs. Thank you. And the last big part of my job with case management is helping fill out paperwork, whether that's FMLA, sick letters, letters out, jury duty letters. So I help facilitate where I can with those. Insurance fund. This percentage, while I would like it to be 10%, especially at the beginning of the year when prior auths all tend to be needing to be renewed at the same time, can be significantly more. And the biggest thing that I deal with is prior auth status. If a prior auth renewal or an initial prior auth is taking too long, I might call the insurance and be like, hey, what's going on? Um, I might help unstick a prior auth. For instance, there was one insurance company that I was dealing with that it had been 2 months and we hadn't heard from them. And it turns out they didn't like the pharmacy that one of their pharmacists selected. And I just was like, well, then tell us where you guys want to send the medication to. And they were just stunned about that. So sometimes it can be a wide variety of reasons. I also help out with denial letters. So if we get a denial for a medication or treatment, I have a template that I kind of generally use, and then I'll add patient-specific information such as disease, and then I'll send that to the doctor, and they'll add whatever pieces they want to the letter to kind of more personalize it and make the case of why they want that treatment. This year has been particularly bad because we got a lot of denials for patients who have been on the medication for some up to 10 years, annoyingly. Their insurance is using bad AI to make some of these denials, which is pretty relevant when you read the letter and you're like, what? Sometimes it's miscommunication correction when I call in insurance, and then very occasionally I have to politely threaten. And what I mean by this, an emphasis of very politely, we had a patient who was a relapse after transplant. He had an active fungal infection and was needing twice a day antifungal IV. After 4 hours, I finally got a hold of somebody to Idaho Medicaid, and I simply proposed, I was telling them they could either approve the medication or they would be paying for him to go in the hospital and get it twice a day IV until they did. And I didn't really care what would happen. They were able to choose. So sometimes just telling them, hey, if you don't do this, you're going to end up paying for this vastly more expensive treatment. So, some tips and tricks for dealing with insurance. Always be overly kind but firm, and I emphasize this a lot. Thank everybody for their help, even if they didn't help you. The big reasons is because the majority of people that I've actually encountered working for insurance want to actually do the right thing. They're there to actually help patients. But if you're rude to them, short, threaten them, outside of the one instance when I recommended, they tend to shut down. So just try to work with them, understand a lot of them hate insurance as much as you do, if not more, and kind of are looking for excuses / ways to stick it to the insurance company. Another point that I emphasize is you need to give insurance enough time to process. For renewals, at least 2 weeks. And that's on the fast side of insurance. If it's a new prior auth, you need to give them about a month, unfortunately, because as I say to the next point, nothing is emergent or urgent to insurance. Even if you're running out of medication, that won't unfortunately push things along. So one thing I like to emphasize to patients is be proactive. If you are on a treatment that you know is going to require a prior auth, you should get a authorization letter in the mail if it gets approved, and that will give you a date of when that prior auth is expiring. So helping your team know that, hey, just so you know, my prior auth is going to expire in 2 months might allow them time to initiate the renewal process a little sooner. So that way there's no interruption of medication. Because the more time you can give insurance to do things, the better you are going to be. if you end up getting a denial letter, and I emphasize this, make sure that you read the denial letter. A lot of times they'll tell you exactly why it was denied, and if it's as simple as they need the last chart note in order to finalize it and get it pushed through. Um, Sometimes it can be very simple. It's not necessarily them just saying no. Um, the next thing is call the doctor to ask about the appeal. Um, Call your physician office and ask if they need any help with it, um, that you are wanting to appeal, and what that appeal process for them will look like. Maintaining open communication with that, um, just because insurance a lot of times I think will initiate a denial letter, and it's very easy to give up. So make sure that you don't give up. Sometimes we want them to try another therapy for the patient. So it's not all hopeless, as much as insurance is hateful. General tips for patients. Um, Oncologists are great in their field, but you do not want them to manage your blood pressure or your diabetes medication. So it is very important to get a primary care provider. And the more specialized the provider becomes, then the less likely that they are comfortable stepping out of their box. So asking your oncologist to refill your levothyroxine or your insulin, a lot of times they're not comfortable doing that, just because that requires labs and monitoring that they may not be set up to do. So keeping care in the wheelhouse of that provider, um, will honestly get you the best quality care. If you need a referral to like a new primary care provider, a lot of times they can help you out with that. Just be forward and saying, hey, I need this. Another big key is know what systems your doctors can prescribe orders in. For instance, if your oncologist office is attached to, say, a hospital system with a hospital infusion center versus their standalone clinic that doesn't have the capability of infusions. Um, Knowing that system can help make your coordination of care easier, um, especially if you end up getting more sick. Um, just being able to know what systems are going to be most effective for you. Um, Another thing is check with insurance for in-network. Um, a lot of times insurance likes to approve a one-off prior auth. So making sure you read through that letter, um, it will let you know does, and if it's not clear, I recommend calling the insurance. They'll be able to let you know, because you may need to have a prior auth every time you want to visit that provider. Um, but this also ties into the next point, is knowing what that consult will be able to do. So are they able to order labs, diagnostic tests such as a bone marrow biopsy, ultrasounds? It's not uncommon for uh, uh, specialists to order a barrage of labs. Um, there is one insurance, Kaiser, that likes to take care of everything in Kaiser. And so knowing what needs to be done in Kaiser before the visit versus what can be done at the visit will end up saving you any surprise bills, which could be quite expensive. So make sure that you go into that with eyes open. Um, some generalized tips for patients, and this is rather critical for MPN patients as well as myelofibrosis patients. Be honest about your symptoms. Make sure the team knows about if you're having night sweats, bone pain, fatigue, and to what extent is it affecting your life, because that is how that they are going to figure out what your needs are Um, the patient is a very critical part of this care team because without the patients, there's no reason for the team to be. So make sure that you are being an active participant and letting the team know when things are happening. Um, if you are, especially with myelofibrosis, if you are on certain medications and you want to start other medications, especially the JAK inhibitors, may not play well with those other medications. So check with your care team and say, hey, I want to try this medication, and they can run it past their pharmacists that can run a medication check and make sure there's no interactions you need to be worried about. This next one is also rather critical: finding good information online. We live in a world where there is everything online, both good information, some very wrong information. And so it is very hard to try to find good quality sources. Um, HealthTree is a good one. And you can also ask your care team if they have any other recommendation of good sources. Another good source is the National Institute of Health. Um, so when you are looking at information online, make sure that you are looking at who is actually writing it. Do they stand to profit from the information? When you are looking up a drug online, a lot of times you might go to the drug website, and yeah, that'll have all of the information you were looking for, but how they present it could be a little bit misleading. So knowing who wrote the information and what are they gaining from the information. Um, that's kind of a important part to remember when you were looking at anything online. And the last thing I want to emphasize is that finding a support group cannot be understated. Um, Having cancer and myelofibrosis is very overwhelming. And knowing that you are not alone and there are others that are going through this with you. It might not be just a myelofibrosis support group, but just a general, but just don't go through this alone. Reach out, and it's okay to ask for help. Um, those are kind of the big things that I was wanting to go over. Um, any questions? You're muted, Dalton.
Thanks. Um, Thanks for that presentation. That was really informative, and I know I learned a lot about what you do. I find your job so fascinating because you wear multiple hats. You're not, and I don't mean this in a bad way at all, but you're not just a nurse. You're also managing cases, and you're going to bat for patients with insurance. Like, you are doing so many things, and that's really why I wanted you to come on and speak about your role, because I think that you help so many patients, and so many patients could stand to benefit from learning about what you do and what your role within their care team is. So, truly, thank you for that presentation. Now is time for questions. So, if you have any questions, you can put them in the chat. That will be, you have to be on the Zoom in order to do that. So, if you're watching on YouTube and want to ask a question, feel free to hop into the Zoom call. Um, no, thanks. I really appreciate it. Oh, cool. Um, let's see here. I wanted to ask, so for your role, I assume that there's a nurse coordinator at most facilities. How do patients get connected with that nurse coordinator and really start establishing that relationship and being able to reach out when they have questions about medication or insurance is not wanting to cooperate? Like, how do patients find individuals like you so that they can really get this sort of help that you offer?
So I am the primary nurse that works with the team. So at, how it works at our institution is each physician is paired with a nurse. And one nurse might work with with multiple physicians. But what you should do is you should ask to speak to the nurse that works with the physician that's seeing you at that organization. They're a good first step. A lot of times, especially in rural areas, they're wearing all of my hats, if not more. And so they're always a good place to start. And if they can't help you with that particular issue, asking, do you know who would be able to help me? And could you help get me in contact with them?
Is again, I think what you do is super helpful. So I just want to make sure that people know how to get in contact with people that are in your type of role. So thank you for that. We have a couple other questions coming in. So do you have any advice on how to go about getting a second opinion?
Um, so that one is always tricky. Um, I always support second opinions. Um, it is the job of the care team to present you with options that meet what your goals are. And it's not something to be ashamed of, to want to step out and make sure that you're getting all of the options presented to you. The best way to go about that would be actually to ask your oncologist if they would be willing to send in that referral. A lot of times, when they send in that referral, it links up medical records. So it tends to speed up that process of getting you into the second opinion much faster. Um, Sometimes it can be a little bit longer wait getting into a second opinion, especially if you're changing institutions. Um, but you could also ask for a second opinion within the office that your oncologist works at. A lot of times there's two or three providers that may work with the disease group. And so asking to see them. But you could also just ask their opinion of, what do you think of getting a referral to Fred Hutch or MD Anderson or another like major cancer center, um, for expert opinions. And a lot of times they're actually open to that, to make sure that you are on the right path that meets your goals, whether that's transplant, medication management, or the watch and wait.
And then next up, we have what do you think about the DIP score prognosis for myelofibrosis? As I assume this is something that you are pretty familiar with. But it's, if not, it's just one of the prognostic scores that's used for myelofibrosis. So it's evaluating all sorts of different things.
That is honestly more on the physician side. And the physicians that I work with actually do use the DIPS score. Um, but the DIPS score doesn't necessarily tell the full clinical picture, as kind of how some of the providers that work at my institution believe in it. Um,
Mhm.
a lot of times they try to take the full patient picture into account, and the DIPS score is a tool that allows them to do that, but it's only a part of the picture, if that makes sense.
And I think that's a really good thing to point out that the scores like DIPS and MIPS and all these other fun acronyms that we have, these are tools, but they're not painting a whole picture. We can't just boil people down to a number. Like they are helpful, but they're not able to evaluate everything. And I think that's a really important distinction that you made there. Um, and then you pointed out towards the end of your talk that patients are really a vital part of the care team. Um, and when speaking with patients, it's not uncommon for them to, I don't know the right word for it, but I found that people sometimes they don't want to sound like they're complaining. Um, but what would you, how would you encourage a patient to really step out of that comfort zone and really advocate for themselves? Say, like, I'm having bone pain, like, because it is very important. But is there any advice that you could give to patients to help them maybe put away some of those fears or those nerves of, I'm talking to my doctor and I don't want to say the
Mhm.
wrong thing or anything like that?
So in medicine, there's two types of data that we get from patients. There's qualitative data and quantitative data. Qualitative is more of like the quality, like I'm having a lot of fatigue. Um, and quantitative is assigning more numbers to that. If you're having bone pain, make sure that you are giving them all of the data of it. On a scale of 0 to 10, I've had some patients say that going 20 out of 10. The scale of 0 to 10 goes 0 is no pain, and 10 is the most amount of pain that you're having. Try not to exaggerate, but be accurate with the pain. Also, tell them, is it aching, burning? The more data you can give them, the more effective that they're going to be able to use that data. And it won't seem like complaining when you are reporting the data. And try not, I know this can be very hard, but trying not to be emotional when you're reporting the data. I know that sometimes it can feel like you're not necessarily being heard, but the more information you present them, the better that they're going to have a picture, especially in things that can be harder, like fatigue. Explain how it has affected your life. What were you able to do before that you can't do now? And so just trying to always present your symptoms as data with as much information for them to be able to figure out how to report that to the physician that they're working with, or if it's the physician, let them know how bad it is, and using information that, or in a way that they can use that information to best alter treatments if necessary or make any other changes.
I like that you talk about on the fatigue, how it's altering things that you used to do, because fatigue is, super common with NPM patients.
Mm-hmm.
But I think it's a really good way to think about it of not just are you fatigued, but how is this fatigue affecting your life? Because that helps your team evaluate just how severe that fatigue is, and that'll help you get the treatment and care that you really need. So that's a really good shift in mindset, I think. Right. And then a couple more questions rolling in. How can patients balance care between local doctors and specialists at larger cancer centers?
So I like to say that the specialists at the larger care centers are more of an admiral, and based on what the patient's goals are, they say this is the general course that we're going to lay into. Then the local cancer doctor is more of a captain. They're driving the ship, they're steering around any obstacles that may be there. Um, and it is a big balance between both. Um, Making sure that the specialist is informed of any major changes, which when they see a patient every 3 months or even every 6 months or even once a year, depending on what's going on, um, making sure that when you do have those appointments, you're letting them know. So this is what's changed. Um, but a lot of times the first person that you are reporting symptoms to, if you're on a treatment that you are becoming neutropenic, that would address like your neutropenic fever, that's your local oncologist. for any emergent things, just know that the closest provider is going to be a lot safer to get care from than necessarily driving all of the way the distance to your specialist. And the specialist may not be able to deal with that in a timely manner. So first try local. And if that is not able to take care of your needs, that's when you should escalate to um, the the larger cancer center provider.
I think that also goes back to what you said about having a primary care provider is really important. Like
Yes.
these specialists, they are brilliant individuals, but they are not always equipped to handle the whole gamut of health. Your
No.
myelofibrosis specialist might be one of the best people out there to treat myelofibrosis. That doesn't mean that you want them handling every aspect of your care. And I think it's important to have a cohesive care team. And a big part of that is having, if you are further away from a large cancer center, having someone a little bit more local that you can go to, or having a primary care. All of that is really important to ensuring that you get the best care.
And we get a fair amount of calls from local providers that are reporting changes to the doctor that I work with. Um, and so there is some communication, and all patients have a right to ask, hey, are you in communication with the specialist about this? Or is this something that you feel should be reported to the specialist?
And that actually segues really well into the next question that we have up here is how can I ensure that my healthcare team works on the same page regarding my treatment?
There are multiple electronic medical record systems, and not all of them communicate. Actually, a large majority do not. And so I always start with making sure that, at least personally, when I call saying, hey, are you able to see these records? Um, and that's something I empower patients to do is you can call your local oncologist and say, hey, do you see the record? Do you see my note that was written by the specialist? Um, and if not, then you can call the specialist office and say, hey, my local oncologist is not able to see the note. Do you mind sending it to them? Um, it will be very helpful if you ask your local oncologist what fax number the specialist should send that to. A lot of times there's a more direct fax number for notes that they might have, and you're just helping save a little bit of time from the nurse at the specialist center. Um, and another thing that I encourage is ask, make sure that they are able to see the records and that the systems are talking to each other. Um, and if not, then just making sure that the specialist team knows of any major events and changes that have happened. Um, a lot of times they may not necessarily need to know about local labs, but if there's been major changes or updates, making sure that those get sent to the specialist provider and that they're kept in the loop.
And then looks like we're coming towards the end of our questions here, but I do have one more. Um, this individual says that their specialist is also their clinical trial lead. Is this a good idea? And then I do have a local oncologist, and there's some communication between the two of them. So having your clinical trial lead as your specialist, how do you?
Um, that actually is a very frequent occurrence when you are going to a specialist center. And that's completely fine. Um, in most instances, they're your specialist first, and then the clinical trial lead second. Um, and so they will always end up wanting to take care of the patient first. If they do not think it's safe for a patient to remain on a trial, they will let the patient know that and say, hey, we shouldn't continue. Um, but that is a very common occurrence. With major cancer centers, a lot of times trials is where the leading medicine is, unfortunately. And all trials come with risks and benefits, and it's making sure that you understand both. Um, and if not, then you can ask the specialist team, hey, I have these questions. Who could I ask this to? And that will get you in contact with the right person.
Just something to add on to that. Clinical trials are super valuable. The patient will always come first, and you have the right to stop a clinical trial at any point if you don't feel that it is the right choice for you any longer. So, like, I always encourage people to explore clinical trials. I think that they are wonderful. It's how we get progression in medicine, it's how we get progression in treatment. But by joining a clinical trial, you are not putting your care secondary. You are not putting the trial ahead of yourself. You still come first. So I just want to make sure that people are aware of that. This is your care. If you are joining a clinical trial, yes, you are potentially helping people in the future, but you're also hopefully getting the best care for yourself. And if you don't feel it's the right choice for you, you have the right to leave that clinical trial at any point in time. So just want to make sure that people are aware, like, you come ahead of the trial.
Um, Piggybacking on that, not all trials are right for all patients. And so it is part of the job of those trial providers to ensure that they're screening you appropriately. And again, be honest with your symptoms with those providers, because sometimes I know that there is a fear that you don't necessarily want to be taking off the trial, but your safety as a patient always comes first. And with that, just a little tidbit, some medications, especially for MPNs, should not and cannot be abruptly stopped without some bad side effects. So don't just abruptly stop taking a medication if you're not feeling well. Call the oncologist office and ask, is it something, like, let them know what side effects you're having and check to see if it needs to be tapered off, because you may end up feeling worse because of the side effects from abruptly stopping. So work with your local oncologist office to stop medications if you're wanting to stop them.
Yeah, that's a very important point to add. So thanks for throwing that one in there. Looks like we're out of questions currently, so we'll go ahead and start wrapping up. But I just wanted to thank you again, Patrick. This was super informative. You did a wonderful job, and thanks for sticking around and answering some questions for us.
Thank you. It was a pleasure being here, and have a great day.
All right. So before we go, I want to highlight the Track My Disease feature in the HealthTree Care Hub. Once you've connected your medical records, you can use the Track My Disease feature to provide you with the ability to gain one-of-a-kind access to your health information, encompassing lab results, genetic profiling, and treatment histories. So this will offer you invaluable insights into your own medical journey. On the screen, I have the link to sign up for HealthTree Care Hub, along with the email address of our amazing patient navigators who are available to help you create an account and connect your records. I'll also include some information about how to enroll in HealthTree Care Hub in our follow-up email, so be on the lookout for that. And then um, I want to highlight a event that we'll be doing on March 3rd. This will be what myelofibrosis patients should know about bone marrow transplants. This is with Dr. Jean Palmer from Mayo Clinic. She is an MPN and transplant specialist, so I think this will be a really good event. And then as you leave today's session, I just want to remind you that we have a brief survey. So if you could just take a couple of moments to fill that out, it really is helpful. And then finally, I want to say thank you for helping us build this myelofibrosis community. I've added my email to the slide, and please don't hesitate to reach out to me with any questions about HealthTree or any of our programs, or even if you just want someone to chat to. I'm always available, and I that's why I'm in this role, is to speak with patients. So I appreciate you all, and I hope that you have a great rest of your day. And I hope to see you at another webinar soon.